This is a continuation session for the online and offline students of NEET PG 2025 exam going students. We are continuing the topic on endocrine surgery now. We will start with endocrine surgery. So multiple endocrine neoplasia syndrome, that's called as MEN syndrome. It's an endocrine tumor. A group of endocrine tumors is called as MEN syndrome. So MEN syndrome, MEN1, MEN2A, MEN2B. Don't forget MEN1 is called as Wermer syndrome. So there are three P problems in this, three endocrine problems in this. It is a menin protein mutation. What are the three endocrine problems means? Hyperparathyroidism. So don't forget, this is a very common problem in this, hyperparathyroidism. Hyperparathyroidism is the most common issue in MEN1 syndrome. So hyperparathyroidism causing increased calcium production and all those things we are going to discuss. And pancreatic neuroendocrine tumor. Okay, pancreatic neuroendocrine tumor is the most important, another important thing, pancreatic neuroendocrine tumor. And in pancreatic neuroendocrine tumor, can you tell me what is the most common neuroendocrine tumor in MEN1 syndrome? Yes, anybody attending the class, please tell me the answer. Gastrinomas. Okay, in pancreatic neuroendocrine tumor, it is gastrinomas, and the third P stands for pituitary adenomas. So 3P includes hyperparathyroidism, pancreatic neuroendocrine tumors, and pituitary adenomas are the 3P in this. So may be associated with the carcinoid tumors in the GIT, and most common cause of death in MEN1 is due to gastrinomas causing a Zollinger-Ellison syndrome, which causes Zollinger-Ellison syndrome is the most common cause of death in MEN1 syndrome. MEN2A, MEN2B, the 100% common cancer in all these patients is medullary cancer. Definitely MEN2A simple, MEN2B, MEN3 syndrome will get medullary cancer. 100%, 40% of them will get Pheochromocytoma. So adrenal and thyroid, two tumors are seen in most of these cases. MEN2A and MEN2B patients will have medullary cancer in 100% and Pheochromocytoma in 40 to 50%. So don't forget this basic point. And parathyroid hyperplasia may be seen in MEN2A syndrome also. Hyperplasia seen, and also Hirschsprung disease seen in MEN2A, and cutaneous lichen amyloidosis. These are the other problems associated with Sippel syndrome, also called as MEN2A syndrome. So MEN syndrome is Wermer syndrome, MEN1. MEN2A is Sippel. MEN2B is MEN3 syndrome. So MEN3 syndrome is a very commonly asked MCQ. There are 4M. The 4M includes Marfan features. There is Marfanoid features, megacolon, mucosal neuromas, and motility disorder of esophagus. So motility disorders of esophagus. So don't forget MEN1, MEN2A, MEN2B. It's a very common MCQ topic for both pathology as well as in surgery. You should not forget this MEN1, MEN2A, MEN2B syndrome. MEN2A, MEN2B will have 100% medullary cancer. Second common cancer in MEN2A, MEN2B is Pheochromocytoma. Never forget this. So 4M seen in MEN2B. Which is not seen in MEN2B is hyperparathyroidism. Parathyroid is not affected in MEN2B. Is a recent MCQ. Parathyroid is not affected in MEN2B. In all the other syndromes, there will be parathyroid involvement also seen, but in MEN2B, parathyroid is not affected. Is a recent MCQ. Don't forget this MCQ. MEN4 syndrome is a new update. It is a different type of mutation. MEN2A is due to ret oncogene mutation. MEN2 is ret oncogene mutation. MEN1 is menin mutation. MEN1 menin. MEN2A, MEN2B is ret oncogene. MEN4B is cyclin dependent kinase inhibitor, CDK-N1B inhibitor. It is also having the same problem like mimics like MEN1. It mimics like MEN1. If you very closely watch, most of the problems will be like parathyroid adenomas will be there. Pituitary and parathyroid is more affected, and it also affects genitourinary areas, reproductive organs, and renal tumors are also seen. I used to remember as 2P, 2R is involved in MEN4. That is what 4. 2P, 2R is 4. So pituitary and parathyroid and reproductive organs, and renal tumors. These are the MEN4 syndrome. So don't forget MEN1, MEN2A, MEN2B, and MEN4. You will be reading this in pathology also. But I want you to remember about MEN2A, MEN2B. Very important topic for surgery exams. MEN2A, MEN2B patients 100% will develop medullary thyroid cancer. So both of them should undergo prophylactic thyroidectomy. Prophylactic total thyroidectomy done for MEN2A at age of 5 years and in MEN2B at age of 1 year. So 1 year you should do prophylactic total thyroidectomy for 1-2B, and by 5 years, before 5 years, you should do for MEN2A. So when will you do prophylactic total thyroidectomy? MEN2A and MEN2B is a very common MCQ topic. MEN2A you should do within 5 years, and MEN2B you should do within 1 year. That much the cancer is very common. Medullary cancer is very common in those two syndromes. So now coming to hyperparathyroidism, the next important topic on hyperparathyroidism. Parathyroid problem is very common in MEN1, MEN2A, MEN4. All of them have hyperparathyroidism. It is an 84 amino acid peptide. Half-life is 5 minutes. Just 5 minutes. Parathyroid half-life is just 5 minutes only. Please remember, parathyroid hormone half-life is 5 minutes, and there are 3 types of hyperparathyroidism. Parathyroid hormone acts on the kidney, GIT, and bones. Along with the vitamin D3, it acts on many organs like GIT, kidney, bones. It acts many places. And there are 3 reasons for getting a hyperparathyroidism. Primary is very common. You have 4 parathyroid glands like this. In a primary hyperparathyroidism, there is either an adenoma happening from some gland, or all the 4 glands enlarging simultaneously. 2 causes are there in primary. So most common cause is solitary adenoma. Primary hyperparathyroidism is a surgery case. Solitary adenoma is more common than parathyroid hyperplasia. Parathyroid hyperplasia means 2 or more glands enlarged and producing the hormones. Secondary is a physiological increased secretion in response to lowered calcium. There is a low calcium for which there is a stimulation of parathyroid hormone. So this is not a surgery case at all. Decreased calcium causes increased parathyroid hormone. It's a natural phenomenon. It is usually seen in people who are having kidney failure and all. Will get the secondary hyperparathyroidism. Tertiary hyperparathyroidism is an advanced form of secondary hyperparathyroidism. The patients underwent the tertiary hyperparathyroidism is an advanced form of secondary hyperparathyroidism in which autonomous secretion of parathyroid hormone occurs despite correcting the underlying abnormality in a renal transplant patient. So it's a advanced form of secondary is called as tertiary. It is following a correction of renal failure. After you correct the renal failure by doing a renal transplant, the parathyroid glands which got autonomous nodules are still secreting. That is called as tertiary. So from surgery point of view, primary hyperparathyroidism is an essential topic for your exam. It is either due to single adenoma or due to all 4 glands enlarged. What is the most common presentation? Can you tell me what is the most common presentation of hyperparathyroidism? Yes. What's the common presentation? Renal stones. So renal stones are the most common presentation of primary hyperparathyroidism. Don't forget this. And when there is a primary hyperparathyroidism, the patient comes to you with the clinical features of bones, stones, abdominal, groans, and psychic moans. So bones, stones, abdominal groans, psychic moans. So simple clinical feature of hyperparathyroidism is given by a simple mnemonic: bone, stones, abdominal groans, psychic moans. What are the problems in the bone? In the problems in the bone, you can see there is a salt and pepper skull. You can see the typical salt and pepper skull. You can see bone resorption causing osteoclastomas called as brown tumor. So the calcium is released from the bones and there is a bone resorption. That is the reason for the salt and pepper skull and osteoclastoma. All these are due to the bone calcium is released into the circulation and the blood calcium is increasing. And there is a stone in the kidney, renal stones, because the calcium is excreted in the urine. It gets renal stones, calcium stones. Abdominal groans are due to pancreatitis. They get pancreatitis. Psychic moans, they develop maniac depressive illness. They develop maniac depressive illness seen in psychic moans. So bones, stones, abdominal groans, psychic moans are the classical clinical features of hyperparathyroidism. You should not forget. And hyperparathyroidism patients may come to you with any of these features. And when you are going to examine their blood sample, that is going to give you a perfect clue because there is increased serum calcium and increased parathyroid hormone. This is a very important blood value. When you're going to examine elevated total or ionized calcium, increased parathyroid hormone, and low serum phosphate, and 24 hours urinary calcium may be increased. And if there is a bone involvement, there is increased alkaline phosphatase also seen. So increased alkaline phosphatase, if there is a bone resorption happening, it is also having increased alkaline phosphatase. Now, what is the localization technique? So I have confirmed from the clinical methods and the investigation, there is a hyperparathyroidism. How I am going to localize? Please understand, investigation of choice to localize parathyroid adenoma or hyperplasia is by technetium 99M system EB scan. So technetium 99M system EB scan is taken by the oxyphil cells. Oxyphil cells rich in mitochondria in the parathyroid problem is taking up this system EB scan and will show you the location of the tumor, whether it is in the left inferior parathyroid or right inferior, wherever it is shown by this technetium system EB scan. After doing this scan, you have to confirm that is there a single lesion by means of also you should do ultrasound of the neck to confirm it the location by technetium scan, and also ultrasound neck is used to locate the lesion shown by technetium scan. Locate the lesion shown by technetium 99M scan, system EB scan. So let us do two tests. In otherwise, I have to do two tests. I have to do technetium scan as well as ultrasound neck and confirm the parathyroid adenoma. And there is a very important protocol. You should not forget. There's a picture showing you a technetium scan showing you there is a adenoma on the left inferior parathyroid. You confirm it by ultrasound. So ultrasound and technetium 99M system EB scan. Both are showing concordant image. So concordant means both are showing this is the problem. So concordant image, what will I do? If both are showing discordant image, both are showing concordant image and discordant image. Concordant image means the lesion is in the same place in ultrasound as well as system EB scan. If it is discordant means ultrasound shows a lesion somewhere, system EB scan shows a lesion somewhere. So concordant image means I can go for a simple surgery called as MIP. What is MIP? By a 3 centimeter incision, as shown in the picture, I can remove the parathyroid called as minimally invasive parathyroidectomy, a small surgery. Just by a 3 centimeter incision, I have removed the parathyroid gland called as minimally invasive parathyroidectomy by a 3 centimeter incision. This is called as MIP. In case of discordant images, don't forget discordant means ultrasound shows somewhere, technetium scan shows somewhere. I should go for a 3-dimensional CT. And 3-dimensional CT shows a localized adenoma. Localized adenoma is there on a CT scan means I'll go for a minimally invasive parathyroidectomy. If CT scan also shows discordant images and inconclusive images, or all 4 glands problem. So there is a discordant image or an inconclusive image or all 4 gland are involved. We go for a major surgery called as open the neck fully and raise the flap, remove all the 4 parathyroid glands, remove all 4 glands. This surgery is called as bilateral cervical exploration operation, a major surgery. This is a major surgery. A major surgery, you can injure the nerves. There are so many complications which can happen in bilateral cervical exploration is done in discordant or inconclusive or all 4 glands enlarged cases. Remove all the 4 glands and keep 1 gland in in left side brachioradialis muscle. If I am a right-hander, you keep it on my left side brachioradialis on a non-dominant hand. So one gland is kept in the brachioradialis muscle. Remove all the 4 glands, keep one gland in the brachioradialis muscle. This is what we do for a bilateral cervical exploration. Remove all the 4 glands and do one gland is kept in the brachioradialis muscle. This is what done for discordant images. So concordant image, I can do a small surgery as shown in this picture called as MIP. There is a very important criteria I should follow now after this MIP. So after removing that parathyroid hormone, measure serum parathyroid hormone level. After removal of adenoma, I should measure parathyroid hormone level. If the level falls more than 50% fall, okay, you have done a complete surgery. Measure serum parathyroid hormone level after 10 minutes after surgery. Because parathyroid hormone has only half-life of 5 minutes. After removing the gland, you measure the parathyroid hormone level. If it falls more than 50% means you have done a perfect surgery. You have done a perfect surgery, no further intervention needed. If the fall is less than 50% fall, so that means what? The other glands are also having problem. You should go for a bilateral cervical exploration and remove all the 4 glands. So if there is less than 50% fall, this is called as Miami criteria. So more than 50% fall means you have done a good surgery, you can remove, you have done a good operation and you have removed all the pathology. If there is less than 50% fall means you have not done a proper surgery, you have to open and remove all the 4 parathyroid glands. So bilateral exploration means all 4 glands removed and keep one in brachioradialis. Keep one in brachioradialis. All 4 gland removed and keep one in brachioradialis. Or else all 4 gland is not removed, only 3.5 gland removed. And leave off in the native place itself. Leave off in native place. Wherever there is a problem, leave off of the gland in the same place itself and give a permanent suture or a titanium clip is marked in future if I want to explore again. So that is usually left in the inferior parathyroid gland. Half of the inferior parathyroid is left. Okay, instead of taking all 4 and keeping one in the brachioradialis, I can leave off in the neck itself. That is called as bilateral cervical exploration surgery. This bilateral cervical exploration is done in discordant images, MEN 1, MEN 2 syndrome, Miami criteria failed, and in multiglandular disease. I will go for a bilateral exploration, like in lithium induced. So these are all indications for bilateral cervical exploration. So most important I want you to remember is when a Miami criteria failed, less than 50% fall, I should go for bilateral removal of all the 4 glands. So thymectomy is also involved in MEN 1 syndrome associated with hyperparathyroidism because the thymus may contain parathyroid glands. So remember, MEN 1 syndrome, thymectomy is also added along with the bilateral cervical exploration. So in which condition thymectomy is also done in hyperparathyroidism means it is in MEN 1 syndrome. This is hyperparathyroidism. So please don't forget hyperparathyroidism related endocrine problem. So hyperparathyroidism is a favorite topic of INISET as well as in NEET PG. So be thorough in hyperparathyroidism. The next important endocrine gland disease is adrenal gland disease. And adrenal gland disease is more important than hyperparathyroidism. And we see more diseases like Cushing syndrome, Pheochromocytoma and all more in the practice. So adrenal gland lesions, just understand the anatomy of adrenal gland. Adrenal gland is containing zona glomerulosa, zona fasciculata, zona reticularis. So adrenal cortex and adrenal medulla. This is medulla and this is cortex. Adrenal cortex is zona glomerulosa, fasciculata and all. They secrete steroids, cortisol. So any lesion arising from the cortex layer will produce steroids and Cushing syndrome. Any lesion from the medulla layer which is going to produce adrenaline, noradrenaline. This is going to cause pheochromocytoma. So 2 important topics, both medicine as well as surgical aspect is A tumor from the cortex produces cortisol producing tumors or Cushing syndrome. And tumor from the adrenaline producing medulla is Pheochromocytoma. So when I take CT scan for all of us, some of you might have a non-functioning adenoma. It's very common incidentaloma. So incidental adenoma seen in adrenal gland is usually non-functioning adenoma. The most common functioning adenoma is Cushing's adenoma, a tumor from the adrenal cortex. So adrenal cortex tumors produces cortisol, steroids. Therefore, they have Cushing's tumor. Adrenocortical cancer can be 4%, pheochromocytoma is 4%, myelolipoma, cyst, metastasis, cons. All these are other incidentalomas from Bailey and Love. So please remember, Cushing syndrome is the most important topic for your exam. The patient has lemon on stick appearance. Patient may be diabetes, hypertension, fractures may be there, and you can see the stria gravidarum pigmentations. So a Cushing syndrome patient comes to you with all these features: diabetes, uncontrolled diabetes, hypertension, some pathological fractures, lemon on stick appearance, pigmentation, buffalo hump. So all these are clinical features you'll be reading in medicine. A Cushing syndrome can be now due to many causes. A Cushing syndrome can be due to the following causes. Please don't forget this flowchart. What is the most common cause of Cushing syndrome? It is very common in people who take iatrogenic steroids for rheumatoid arthritis, for ulcerative colitis, something they'll be taking steroids. So because of that, steroids, getting Cushing syndrome is the most common cause. And other important causes are ACTH is an important stimulus for cortisol. So ACTH independent and ACTH dependent. ACTH dependent means the problem is not in the adrenal. Please understand, the problem is not from the adrenal. Understand the physiology. This is adrenal medulla, which is secreting adrenal cortex, which is secreting cortisol. Cortisol from the cortex of the adrenal, zona glomerulosa or fasciculata. This is stimulated by pituitary gland, which produces ACTH. That will go and stimulate the cortisol production. Once the cortisol is produced, it will go and produce feedback inhibition of ACTH. This is a cycle. So ACTH independent means there is no problem in the pituitary. It is a problem in the adrenal source. Probably an adrenal medulla. This is a adrenal adenoma. This is 15%. ACTH dependent source means the problem is in the pituitary. There is a pituitary adenoma. Pituitary tumor, which is very common. 75% of the patients, there is a pituitary tumor that is producing ACTH, that is causing cortisol production. This is called as Cushing's disease, also called as Cushing's pituitary problem is called as Cushing's disease. So remember, disease means a pituitary problem. Disease is a pituitary problem, and there is an ectopic ACTH production, very rarely seen in small cell lung cancer, and many other cancers can produce ACTH ectopic. That is also 10%. So now my aim is a patient comes to me with with all these clinical features, and when I measure the cortisol level is very, 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 very high. So how to know what is the source, whether it is an adrenal pathology or a pituitary pathology or a pathology from the ectopic ACTH? There is a flowchart. I want to know the source of this problem. So adrenal source, pituitary source, ectopic source. There are three sources now for producing this pathology. So let us differentiate these. Diurnal variation. You should not forget there is a very important problem in cortex. So all of you know very well the adrenal cortical hormones, cortisol. Steroids are highest. Steroid production in your body is highest during what time? Steroid hormone secretion is highest at early morning, 4 to 6 a.m. It is highest at 4 to 6 a.m. and then afterwards it declines. In the evening and all, it will be low. In the early morning, it is very high. This is a diurnal variation. This diurnal variation is seen only in pituitary problems. In pituitary problem related cortisol secretion, the diurnal variation is present. In adrenal and ectopic, it is absent. And now the most important test is measure the ACTH level. if it is a pituitary source, you can see pituitary ACTH is increased. Pituitary level ACTH is increased. See, already we have measured the cortisol. Cortisol is high. Cortisol is high. Therefore, I am going for the source detection. Diurnal variation is seen in pituitary source, not seen in adrenal or ectopic source. ACTH is high in pituitary source and very, very high in ectopic ACTH source. Whereas, since cortisol is produced from the adrenal tumor, the ACTH will be very much suppressed, less than 5. Less than 5 is there in adrenal source. Lowest ACTH in adrenal source. And the third test we do is high dose dexamethasone suppression test. If I give high dose dexamethasone, adrenal source, the cortisol will not increase. Okay, so the ACTH will not be varied. There is no variation. If I give high dose cortisol also, ACTH is not altered. ACTH not altered. Whereas in a pituitary source, when I give high dose dexamethasone, the ACTH decreases from 500 to 50. So diurnal variation is present. High dose dexamethasone, ACTH value decreases, and ectopic source, there is no such point. So now I can confirm. So which are all the findings in pituitary source? Please remember the pituitary source, the most common problem in the sources is pituitary, which is 75%. You should not forget, pituitary source has diurnal variation. Pituitary source has ACTH level between 15 to 500, and pituitary source high dose dexamethasone, ACTH level decreases. In other two, there is no change in ACTH level. So dexamethasone suppression test is used in pituitary source. So now if it is a pituitary source, take a pituitary MRI or a petrosal venous sampling from the inferior petrosal sample and go for a surgery in the pituitary, which is not related to this chapter, a neurosurgery. A transsphenoidal surgery is done for those patients. Or we can even go for a non-surgical method called as stereotactic radiosurgery. So SRS is stereotactic radiosurgery. Stereotactic radiosurgery is done for those patients. Stereotactic radiosurgery is done for selected cases. So that is very important. Stereotactic radiosurgery done for pituitary sources. When it is an adrenal source, that is my job. So when an adrenal source comes to me, I will take a CT abdomen and confirm there is a lesion in the adrenal cortex like a adenoma, or it can be hyperplasia. Adenoma means single gland having an adenoma. Hyperplasia means both glands are enlarged. So whatever it is a problem, I have to confirm it. If it is an adenoma, I will remove that adrenal gland. If it is hyperplasia, I will remove both the adrenal gland. That is most important thing. If it is an ectopic source, I should rule out squamous cell cancer of the lungs, carcinoids, any pheochromocytoma, bronchial adenoma, and I have to go for multiple investigations, including somatostatin receptor scintigraphy. So all these are not needed for your exams here. You should know adrenal problems now. Adrenal adenoma related issues you should not forget. Adrenal adenomas will have low ACTH level and no dexamethasone suppression test value. So adrenal source is confirmed. Go for a unilateral or bilateral adrenalectomy according to the pathology found. Adenoma means unilateral adrenalectomy. Hyperplasia means bilateral adrenalectomy. So for the NEET PG exam, the most important pathology is pheochromocytoma. Tumor arising from the adrenal medulla is called as pheochromocytoma. Please don't forget. Catecholamine producing tumor from the adrenal medulla is pheochromocytoma, and arising from the sympathetic chain is called as paraganglioma. Both of them have same features. Paragangliomas are nothing but extraadrenal. Paragangliomas are extraadrenal. Pheochromocytomas are called as paragangliomas arising from the sympathetic chain. So extraadrenal pheochromocytomas, also called as PGL, paragangliomas, is most common in the paraiotic region in organ of Zuckerkandl. Organ of Zuckerkandl is bifurcation of aorta. That area is having increased sympathetic ganglions. That is called as organ of Zuckerkandl. That's a very important MCQ. Most common site of extraadrenal pheochromocytoma is organ of Zuckerkandl. Don't forget this. Organ of Zuckerkandl. It is also seen in thoracic, bladder, neck, pelvis. Anywhere it can happen along the sympathetic chain. Wherever there is a sympathetic chain, you can get a tumor. It is most commonly in the paraiotic region, and syndromes associated are MEN2A, MEN2B, Familial paraganglioma syndrome, von Hippel-Lindau, Sturge-Weber, all these are syndromes associated with pheochromocytoma, and people call pheochromocytoma as 10% tumor because 10% is extraadrenal, 10% seen in children, 10% familial, 10% bilateral, 10% recur, and 10% may be malignant. And this pheochromocytoma patient comes to you with a typical triad of increased adrenaline, noradrenaline production, and adrenaline production causes, you know what is the function of adrenaline? It will cause severe hypertension. Hypertension. When there is a hypertension, you will immediately get headache. Headache. Most common presentation is headache. Due to hypertension, the common presentation is headache, and they may get sudden palpitations and sweating. Palpitation and sweating. So this is a triad of pheochromocytoma: headache, sweating, palpitation. Is this always seen? No, it is not seen always. This is all paroxysmal when there is a sudden stimulus. Paroxysmal means it is seen on and off. Suddenly it may happen within once in a week or once in a month or once in a day also. Sometimes it can happen depending upon the situation. So it is paroxysmal, sudden increase of BP causing palpitation, perspiration, and pain. So 3P is a finding seen in 50% of the pheochromocytomas. It is odd, but it is not always seen. It is paroxysmal, and pheochromocytomas from the adrenal medulla produce noradrenaline mostly. Extraadrenal, I told you, paragangliomas. They don't secrete adrenaline. They will only secrete noradrenaline only. So pheochromocytoma secretes noradrenaline more than adrenaline. Paragangliomas secrete only noradrenaline. There is no adrenaline. And pheochromocytomas in men syndromes secrete only adrenaline. So like men 2A, men 2B, I told you. These two syndromes will have only adrenaline. Malignancy means they may secrete dopamine and homovanillic acid. So what is the screening investigation? Means the screening investigation for pheochromocytoma is plasma metanephrines. Metanephrines plasma is measured. Plasma metanephrines is increased. You should think of pheochromocytoma. So please remember, plasma metanephrine is a screening investigation. When somebody coming to you like this, immediately ask them to undergo plasma metanephrine. If it is increased, there is a chance, not always, there is a chance of pheochromocytoma. If it is borderline, I will also do one more test, that is clonidine suppression test. That is also used to diagnose investigation of screening. Clonidine suppression test. But what is the best test if you ask me? The investigation of choice to diagnose is 24 hours urinary dash. What is the answer? Yes, please tell me the answer. 24 hours urinary. What is the diagnostic investigation? 24 hours urinary. Metanephrines and vinyl mandelic acid. Yes, very good. So vinyl mandelic acid is second best answer, Sambat. First answer is metanephrines. 24 hours you have to measure metanephrine. Second is vinyl mandelic acid. So screening investigation is plasma metanephrines. Investigation of choice is 24 hours urinary metanephrines followed by VMA. Investigation of choice to locate adrenal as well as extraadrenal both is MRI. MRI will show you Swiss cheese pattern. Swiss cheese appearance of the lesion in the adrenal medulla will be seen on MRI. So MRI is the investigation of choice both for adrenal as well as in the paraiotic. Both of them can be diagnosed by MRI. Usually we don't do contrast CT because contrast can stimulate the pheochromocytoma crisis. That is why MRI is done. So even investigation of choice to locate extraadrenal also MRI only. So adrenal as well as extraadrenal, both answer is MRI. So don't forget this MCQ. For adrenal as well as extraadrenal, we have to go for MRI only. So MRI is the investigation of choice. To localize, they will have a Swiss cheese appearance. So to detect the metastasis, once upon a time, we were using MIBG scan. Meta, iodo, benzyl, guanidine scan. New Bailey has replaced this scan by DOTA-TATE. I hope you know what is DOTA-TATE scan. DOTA-TATE scan is now used. So using DOTA test, we are now using to diagnose metastatic and ectopic pheochromocytomas. So this DOTA test scan is used for ectopic and for metastatic. Mainly for, not even for ectopic, mainly for metastasis, this is used. Because most of the extra adrenal can be picked up by MRI itself. Okay, don't forget this. So now operating a pheochromocytoma is a real challenge for anesthesiologist than the surgeon. Anesthesiologist, the BP will be 240 by 180 like that. They cannot give the surgery. Especially when the patient is shifted to theater, there will be high BP. What they will therefore do, they advise you to take phenoxybenzamine, alpha blocker. Alpha blocker given until patient develops low BP, going for postural hypotension. The patient should go for postural hypotension. Until then, you should give phenoxybenzamine. So alpha blockers are given until the patient is going to go for postural hypotension. Beta blockers are given for tachycardias and arrhythmias. So beta blockers should not be started until you get the complete alpha blocker. So beta blockers are started after complete alpha blocker. Otherwise, there will be a rebound increase of BP. Okay, so don't forget, this is a basic pharmacology you should understand. Alpha blockers should give completely until the patient gets postural hypotension or nasal congestion. At that time, you should start this beta blockers. And treatment of choice is ideally laparoscopic adrenalectomy is preferred. Instead of an open operation, laparoscopic adrenalectomy can be done even up to 10 centimeter size of pheochromocytoma. You can remove by laparoscopy. So anesthesia of choice is enflurane is the drug used in anesthesia. Sometimes some drugs can stimulate the pheochromocytoma. So the people give short-acting drugs like enflurane, and laparoscopic adrenalectomy is a treatment for pheochromocytoma. So don't forget these three endocrine problems: hyperparathyroidism, Cushing syndrome, pheochromocytoma. All these are essential topics for your national board as well as INISET exams. Okay, don't forget these three. Okay, high yield MCQ topic for your exams.